Thank you very much. I know there are a lot of people. I have a dumb question. When you go back to the Canadian criteria and your cutoff of 2, just to go backwards, that at least for PEM and some of the other criteria, in fact, not 100% of the people had the symptom, and even though that's an essential symptom. So if you could just explain to me how that works, because I didn't get it.
And was it PEM that you were particularly interested in?
Well, I was thinking about PEM, and I was thinking about, because I think sleep and fatigue were pretty high up there, but PEM and...
Can you go back?
I just want to, maybe just one measure out of the many,
So you're saying why doesn't 100% have it?
Yeah.
Okay. Well, excuse me?
It's the bar graph we're trying to get to.
Okay. Yeah. So think of it this way. Even. Yeah. Okay. So think. These self-report questionnaires are not perfect, and they have problems with that a person, for example, might experience a particular symptom, but as we assess that particular symptom, we might not be getting it. So that's the first thing. It's a reliability problem even within these questionnaires. Number 2, it's very possible that some individuals in the sample don't have the symptom. And if you think about it, these individuals are being referred in from specialty clinics. They supposedly have all the symptoms, but it turns out that some small numbers don't have some of the core symptoms. So if I were to think of what at least these data suggest to me is post-exertional malaise is a core symptom. Now, an individual might not have any particular symptom, but think about it. It's also the phrasing of that question. So maybe they don't get it for one particular item, but they might get it for another item. So if you basically said, has someone got one of those 5 PEM symptoms, I'd have to give you that data to sort of say how many people had none of the 5 symptoms. So if you ask a question several different ways, you have a better chance of hitting that, what's really a hypothetical construct.
Okay, thank you. That's very helpful. The order is Margarita, Nancy, Betsy, and then Lily.
Thank you so much.
Peter, I skipped Peter. Peter was before Betsy.
Thank you so much for your presentation. I actually have a lot of questions, so bear with me. Well, I have quite a bit of questions. I think and if you want, you can write them down, or I can give them to you. And basically, one is a question about, have you done ROC curves to see sensitivity, specificity?
Let's just stop there, okay? I'll just maybe go on one at a time, otherwise.
Okay.
Yeah.
To look at positive subsyndromal.
Let me just kind of stick with that one, okay? And then we'll take the second one. Now, otherwise, I might miss some of the ones. Yeah, we have a couple articles that we've just actually submitted, and we have 54 items that we have looked at in terms of their ability to differentiate 2 groups. And we have found very, very interesting post-exertional malaise items, neurocognitive items, and sleep items come up in terms of the items that best make those differentiations of the top 10. We then kind of try to say, from a different set of analyses using a 2-2 as well as kind of what's called unsupervised learning, whether the same items would come up. And again, we find similar items. Our last strategy was to do what's called artificial intelligence, which is called data mining. And we basically, the reason that that's a better technique is because you put all the items in at once, and you get decision trees, and you find out what items come out. And we've been able to identify, again, just a few items that can best discriminate the 2 conditions. But we start with the ROCs. And ultimately, what's really interesting is that when we do these analyses, we do 100 trials so that we can see where we take a probability sample and then we replicate it 100 times, whether we get, which items come out the best. And we think we've been able to identify items that are best discriminators. And they tend to be in the domains that we continue to mention, post-exertional malaise, and the neurocognitive, and the sleep, so as well as fatigue. So that's something that we have, a number of papers and one that we just submitted. And if you would like to see our most recent kind of effort to tackle this issue, we'd be happy to send it to you.
That'd be great. I think in that same line, and it's in response to one of the questions that Ellen had, could you were you able to identify what differentiated the people that were out of the CFS when you used the two symptom threshold versus the one symptom threshold? Any particular thing about that group that got left out?
Okay, when you're saying two symptom, you're saying like a 2-2?
The 2-2 versus the 1-1.
Frequency and severity?
Who are the people that get dropped out? And could you identify characteristics of that group that gets dropped out? Is it the people with gradual onset? Is it the people that have psychiatric comorbidities? Anything in particular that could differentiate those two groups?
We have not studied that.
Okay. I guess one of the questions is, have you done item response theory to try to see whether there might be differences in the responses, like you were saying, either because of gender, ethnic differences, issues that have to do with severity level?
Those are all things that we would like to do, but at the present time we haven't done those studies. We kind of feel in some ways we're sort of scratching the surface with just the most basic analyses, and our hope is that over time, we will start looking more intensely at some of the type questions you looked at.
And then missing data. One question I had in looking at sort of the literature reviews summary, so I didn't read the complete abstract, the complete study, was how are you handling missing data?
We have a whole section in this most recent paper that we've written on that we basically have the missing data when it has occurred. We've taken it out so that we have basically comparable amounts of individuals in the kind of patient and control group, and missing data we've basically taken out. So we have a little bit of a smaller sample, but our data we're pretty secure on it. Again, probably the best way of me answering that question, because it's about a page within the manuscript of talking about how we dealt with that missing data issue.
And I could keep on asking, but one last question, because I know my other colleagues have many questions. I'm always confused about when you say controls. What sort of are you matching on to make adjustments for other things? Could you talk a little bit about confounders that you are taking into account to make sure that what's really differentiating these two groups is the CFS and not other things that might not be adjusted for?
Yeah, that's a good question in terms of, and again, just remember I've probably talked about 12 different studies up here, in this last half hour. So the controls are really very different for different studies. Ultimately, what you want is you want to have several control groups. You want to have a healthy control group, a control group that's as physically inactive as the patient group. You want to have a control group that ultimately, doesn't have potentially is in the same families or if there's any contagion effect. So yes, there's lots of controls that you ultimately want in the best controlled studies. And I can just say that, this is the gold standard of getting the controls right. A number of the studies that we're talking about were samples where, for example, we didn't collect the CFS Association Biobank data sample. So we sort of have been able to get access to that. And some of the other data sets that are out there, I would say that if you really want to do it right, what you want to do, and I would just kind of take one step further, is you want to do a complete medical and a psychiatric examination of everyone. You got to do that because Unfortunately, we're not very good at identifying psychiatric issues among individuals. Physicians aren't trained to do that. They typically miss many types of things like substance use disorders, depressive disorders, and other things. So you really want a specialist for a medical exam, specialist in a psychiatry, psychology, a structured clinical interview, for example. You want the best of both domains, and then you want to have carefully defined patients with the case definition that I know that you're all working on, as well as controls that are, again, kind of several different control groups in your best situation. And you also want to ultimately put them through a challenge. And then the final one is you want a tertiary care sample and a community sample. If you can do all those things, then you've got it perfect.
Just a couple of questions, Lenny. I mean, you can see the position of this panel and what we're trying to achieve. That was tremendously helpful, and these slides in particular helpful. I'd say first is, as a clinician, some of those people that failed to endorse, or because you recruit them on a bad day, they come in on a day when they feel better because they're not well enough. And then they feel better, and it's sort of a relative to how I usually feel. So they interpret the question in a kind of fuzzy kind of way sometimes. So I think that's very interesting. You were saying that there are some other illnesses that have a structured sort of moving case definition strategy, and I'd like to know what they are.
I'm sure people on your panel who represent different kind of illness conditions probably can have their own experiences. Because I'm in psychology, we have something called the Diagnostic Statistical Manual that has started in the early 1950s with DSM-1 and has evolved to today what we call DSM-5. So it's actually gone through 5 iterations over this kind of 45, 50-year, 60-year period of time. I might add that DSM-1 was basically an unreliable instrument, and DSM-2 began to get a little bit more reliable, and the reason is that they started specifying what particular symptoms represented a particular illness, like schizophrenia. But unless you specify what the symptoms are, you have this problem of criterion variance, and that's what really plagued the field that I'm in for almost 20 years. The second problem was once they identified the symptoms that were critical, they then had problems with making a decision of how to assess it. And that's when the structured clinical interviews came in the 1970s and 80s. And the diagnostic interview schedule, structured clinical interview, these are types of things that were developed to measure the domains. And when you tackle those two issues, then at least what you had by DSM-3 and DSM-4 is something that was reliable. Then the question is, once you have something that you consider reliable, you can start working on validity. Does it measure what you really hope it does? Is it continuous? Is it categorical? And there's statistical tests you can do to kind of probe that. But you've got to get the reliability issue dealt with first. And our field, which started really, back with Ramsey and certainly with Holmes, we haven't really dealt with this issue of reliability. And I would say if we could tackle that problem, we would do an enormous service to the researchers, to the clinicians, and ultimately the patients.
Question. I mean, certainly in the literature, some of the best of the literature on case definitions is coming from your group. And I would really love to hear where you think, what kind of result you think that we might have from this panel. The one issue is a clinical case definition versus a research case definition. We don't want to I would think, this is my own personal opinion, make a clinical case definition that's too complicated for a clinician to put into play. On the other hand, we do want to have very clear, we would hope to have clear and possibly evolving research case definitions.
So I guess my recommendation is, when you come up with kind of which case definition you decide to endorse, or if it's whether it's a new case definition, whatever you come up with, what I would suggest is it needs to be, in a sense, hopefully matching some of the data that you heard in the panel, some of the data that has been talked about. Certainly there seem to be some core symptoms that the Fukuda criteria doesn't require. And that's one of the benefits of the 2003 Canadian criteria, as well as the MEICC criteria. However, that's not enough. And if that's the only thing you do, then the problem is we're going to have clinicians in different parts of the country who are going to try to interpret these definitions in a way that are going to have reliability problems. And they're not going to have the sophistication to basically be able to determine whether a person meets these criteria, whatever they are. And again, it might seem like a simple exercise, but I've seen enough data at this point where individuals who are general practitioners who are asked to make these types of judgments don't have the types of training that you folks all have. They're pretty busy and they're doing lots of things. So if you want to help their kind of task, what you will do is whatever you come up with, you will ultimately do it in a way that there's something that goes along with it. So there's a way easily for them, and I think that's one of the questions you asked me, is there a screening instrument that you can give individuals that can give them the diagnosis, that can score it with an algorithm? There's no reason that you can't have that done as a stage 1 trial so that you can say, yes, they meet the criteria. Now let's do a physical exam and a psychological exam so that we can rule out all these other potential contributors to their fatigue and make sure they really have the illness that you're thinking about.
We're out of time, but what I'm going to do is I'm going to make 5 more minutes, and there are 4 more people wanting to talk, so please be mindful. Peter's next, then Betsy, then Lily, then Charles.
Lenny, this was very helpful, as others have said. I had a question that's been plaguing me about the way we classify depression. You've talked about how people with depression can be differentiated from people with CFS because they don't have self-reproach, and the depressed patients benefit from exercise rather than decline afterwards. What do you do with the people who you're pretty sure had CFS to start with, but as perhaps a consequence of the demoralization and frustration with the illness, move into depression? And so on their Beck Depression Inventory scores, there is a bit of self-reproach, and there is a bit of negativity about their own self-image. How should we handle that?
You know, I think that you heard on the panel that sometimes when people get like this CFS diagnosis, then we don't think that they might not have anything else. And I think it's clear that, you know, there are many other illnesses, diseases, or psychiatric states that people can enter into in life. And, you know, when you have a devastating illness that robs you of your energy, of your work, often of your status within your family and friends, I mean, the fact that some individuals might get demoralized, feeling hopeless, I mean, it's certainly something that's going to happen with some patients. So I think that's why ultimately this kind of goes beyond, I guess, you know, this committee, but you want a multidisciplinary team. You want the best of medical field that can handle all the different and complex issues that come up with the patients, who often have many different things that are happening to them that need to be treated. And we can't just sort of put them off to one discipline and say that's kind of what we're going to do with them, because we don't treat anybody else like that. Why should we treat these patients that way?
I have a question about your study that you presented, the community-based study versus the tertiary care study. And actually, I was curious about, on that slide at the end, you remarked about the symptom criteria were higher among the tertiary sample, which was predominantly white females, and you have percentages for the various symptoms. So my question is, what were the most prevalent symptoms in the community-based sample? Do you recall what that data showed? So you've got memory and concentration problems, 96% in the tertiary sample, but only 74% in the community-based sample. So I'm just kind of curious what rose to the top with the community-based sample in terms of symptoms.
I'd have to go back to my article. I could look it up. It would take me 5 minutes, but I don't have that data in front of me.
Well, it just suggests that there's either they're truly exhibiting different sets of symptoms, or which is something we needed to think about. Obviously, they're displaying differently, or they're reporting differently, I suppose.
Well, one thing that has come up in our group and some other groups is that the onset issue, and that's it does seem like the onset seems to be, as defined. Within tertiary care samples, you get more sudden onset. Within community samples, you get more gradual onset. So that is something that seems to occur, for whatever that's worth.
So I've mentioned this to Lenny before, but just another factor that could influence the prevalence of PM is because the items are phrased as after exercise. If there are people who no longer exercise or have adjusted their activity because of the CFS, they may not be experiencing PM anymore. It's only asking about PM in the last 6 months. So I can adjust my level of PM to below 2/2 if I really limit what I do. And one thing I've talked to Lenny about is maybe putting some stem in there about if you try to do what you would normally did pre-illness, would you still have PM? So that's just something I wanted to say. And then I have a question about the studies on ethnic minorities. These are community-based studies, and I'm trying to recall, Lenny, but were these people, besides answering questionnaires, brought in and examined clinically? Because a large issue with ethnic populations is healthcare access.
In our EPI study, we identified individuals who had some of the classic symptoms. We brought them in for a complete medical and psychiatric examination. And I might add that one of the reasons that we were able to bring so many Latinos in was because we had individuals who were bilingual, bicultural, so they were able to do the interviews in Spanish. Had we not had those types of sensitivity in our assessment, we would have never brought those Latinos into the sample. Just real quickly, in terms of PEM, some of the other items that we don't have actually exercise in all of them. We have like drained after mild activity, and soreness and non-strenuous activities, soreness after non-strenuous activities, and mentally tired after slightest effort. So those are some other items that make up that PEM domain. And again, what we tried to really do is have questions that really had all the different aspects that we thought of PEM. But clearly, there are some individuals who are not going to endorse that because they're possibly staying within their energy envelope, very careful, and not experiencing these symptoms at the present time.
Oh, it's short. Just some technical questions. These people may know, but what's your recall period for the symptom?
Well, recall's an interesting issue. In our DSQ, it's the past 6 months. We just had one of our students who did a master's thesis where we basically looked at a week, a month, 6 months, and we looked at different domains of that and how it affected patient responding. And our conclusions after some pretty sophisticated statistical tests, and that paper is in press, so if you would like a copy of it, we'd be happy to share it with you, was that our analyses after many kind of looks at the data was that the 6-month period was the best.
Second question is, have you tried, you do the 2+2, have you tried only intensity or severity?
Yeah, we actually, I kind of referred to, boy, this one gets a little bit technical, but what they do is called unsupervised learning, where you have, in a sense, you don't sort of say a 2-2, but you have like frequency and severity on a graph, and you basically do a k-means cluster analysis where you take all the people and you put them into 2 clusters, and those who are high versus those that are low are the 2 clusters, and you put a line that between those 2 clusters, and then you basically kind of differentiate the high versus the low, and that basically score on frequency and severity will change symptom by symptom. So that's what kind of unsupervised learning is, and we do work with, again, the work that we're talking about here is really something that involves many disciplines. So we're working with people in the computer science department at DePaul, Jacob First and his colleagues, as they look at very large data sets and they try to help us make sense of them through these types of procedures. But yes, we're trying to use both simple strategies of like a 2-2, which is easy, but we also are trying to use very mathematical strategies of what does the data say and can that give us better discriminations.
But if you were to do these charts based only on intensity, would they be somewhat varying from this?
Yeah,
let me just preface this.
Sure.
I'm into screening symptoms, right? And the more complex we make it, the more time it takes and the less frequently it's done. And we looked at correlations between frequency and intensity and found them very high. And so we dropped back just to severity. And what would you lose doing that?
I think, can I ask you what type samples you're dealing with?
These are primarily cancer patients.
Okay. Yeah, and cancer fatigue is, again, has a lot of fatigue in it. I think that's, I mean, I certainly understand that. I would say that, you know, if you use that type of severity, I'd like to sort of see the item, you know, because some severity items kind of bring in some of the frequency domains also. My concern a little bit is that there are some items that people experience as extremely severe, but that they don't occur that often, so that they're not debilitating and they don't have that much meaning for the patient in terms of something that becomes kind of a real obstacle to their daily functioning. So we're primarily looking at how do we best kind of focus on that domain that basically says, yes, when you hit that criterion, it really is, it's significant for that person's life. And our feeling is that particularly those researchers who are using mild symptom severity, which there's actually quite a few that are using that as the cutoff point. I think they are unfortunately, you know, missing an important domain of, you know, they just are probably not bringing in enough of the, you know, the people who have these more, the symptoms of this illness, but possibly are bringing folks in from the general population.
I totally agree. I think moderate is the cutoff.
Yeah.
Okay, thank you very much. Dr. Kishi, we are ready to hear you about sleep. Thank you so much for coming. And thank you, Dr. Jason. That was obviously incredibly informative and elicited the kind of probing questions that I warned people of at the outset.